Hello, welcome to the Department of Respiratory Medicine at West Hertfordshire Hospital's NHS Trust for linear endobronchial ultrasound. Our next case is of 82-year-old gentleman who has got good performance status of 0. Unfortunately, he had abnormal chest X-ray for chronic cough, which then subsequently led to staging CT. The staging CT confirmed multiple lung nodules with mediastinal and hilar lymphadenopathy, as well as bone metastatic disease. In the view of bone metastasis, this procedure will be for diagnostic purpose only. Chin lift, please. The chin lift helps to get intubation slightly easier. So I'm at epiglottis now, looking at the vocal cords. From intubation point of view, you should aim looking at the apical part of the vocal cords where they join, and then slowly go in.
And the key feature here is that with the technique of the cricothyroid lignocaine injection, the patient shouldn't cough at all. So we've gone through the most sensitive part of the body without any stimulating cough.
He's very comfortable.
Yeah. Can I have some lignocaine, please?
So just to summarise the case, I know you've just introduced it. This is an 82-year-old gentleman who has a performance status, as you say, of 0. He's still
Indeed.
playing golf.
And regular
Still
swimming.
playing golf. And so he just had a minor cough, is that right? And
Chronic
the
cough
chest-
for about 7 to 8 weeks.
And the chest X-ray obviously showed a mass, and that led to the CT.
Yes.
So for staging-wise, with the multiple nodules in your staging classification, this gives you T4 disease?
Yes, so there are multiple nodules on the right lung. There is a small nodule on the left, which is just about 5 millimeters,
Yep.
which could potentially be suspicious. However, in the view of multiple ipsilateral lung nodules, it's going to be T4, definitely N2 seen on the CT, and potentially N3 at 4L, station 4L
Okay.
AP window. However, there are multiple bone metastases, including ribs, that gives M1C.
So it's M1C, so T4, N2, N3,
M1C.
M1C. Okay.
And just and also just for the benefit, we're using 2% lignocaine endobronchially, and we tend to put in at the start 3 lots of 2 mils of 2%.
Okay.
Can I just confirm how much sedation has he had so far?
Just 1 milligram. 1 milligram of midazolam, that's it.
That's it.
Yeah.
Excellent.
Okay.
So he's looking very comfortable. Sats
So
are 99, pulse is 80. He's
Yeah.
Yeah, the
Very
idea
relaxed.
is
I'm very quickly going to talk about the 6 landmarks which have been mentioned in the combined guidance from European Society of Gastrointestinal Endoscopy, European Society of Thoracic Surgery, and European Respiratory Society. Now, I want to make it clear that this guidance is primarily for the beginning or beginner operators, because it
for
does
trainees.
indeed,
Yeah.
because it does miss number of stations which can be accessed and appropriately used for staging. So the first landmark point is station 4L. For endobronchially, you basically just come 1 cartilage interspace above from carina, then turn anti-clockwise to 9 o'clock.
so that's 90 degrees anti-clockwise.
Anti-clockwise.
Ray, could you just
Yeah.
take the we need about 6, depth of field needs to be about 6 to 8 centimetres, please.
Yeah.
Because what
And
we're wanting to show is the relationship of the aorta and the pulmonary artery, and which is
Indeed.
nicely shown on the
So we're
ultrasound.
already having a number of structures here.
So if you leave the pointer there, Ray, that's the pulmonary artery.
Mhm.
yeah,
And the other big vascular structure on the right is the aorta.
indeed.
Great.
And the structure in the centre of the screen at the top is an enlarged lymph node, and we'll come back to the characteristics of that. But that's a 4L lymph node,
Yes.
So this is in my language, the AP window, the
Yeah,
aortopulmonary
window.
otherwise
window.
known as the aortopulmonary
Yeah.
window.
Yeah.
I think for those who read left to right, we should probably call it the PA window, with the pulmonary artery there and the aorta there.
Yeah.
And this is your scale here. So the scale is down at 20 millimeters.
Yep.
Yes, it's
So
just
this
about-
is a sizable lymph node.
It is
Indeed.
indeed.
I mean, because we got such a clear picture, we might talk about lymph node characteristics now.
Certainly we can do. So
Yeah.
we
Okay.
pre-biopsy.
Shall I just,
Pre-biopsy, we characterize the lymph nodes, and we then match those characteristics with the resultant cytological diagnosis. So we give the size, which is
1.8.
1.8 centimeters.
Yeah.
It's heterogeneous in terms of the echo architecture.
yeah.
There are areas of darkness, which Dr. McCrudden was just highlighting there, and that's central necrosis.
Indeed.
Yeah.
And if Rahul can just show us the entirety of the lymph node, just want to see if we can find a hilar structure.
There's an adjacent.
That's
one
a
Adjacent,
there.
separate
indeed.
node.
Yeah.
I can't see a hilum there at all, so there's no central
No,
hilum.
no.
It's round
It's
and distinct margins.
Yeah. Yeah.
So one of the paper published, which sort of Dr. Barlow did mention in between cases, there are a number of literature evidence, but one of the key paper which was published talks about 4 features, which is round, heterogeneous echogenicity, loss of central hilum, and
Central
distinct,
necrosis.
and distinct margins. If those features are present, it is highly suspicious for malignancy or malignant involvement. If all these 4 features are absent, there is 96% probability that it will be benign. So based on that, so they analyzed about 500 patient cases in their research work.
Okay. So again, rounded
Round,
morphology,
heterogeneous,
heterogeneous.
no central hilum,
Yep.
And necrosis.
and
central
central necrosis,
Okay.
the 4
Yeah.
features.
But interestingly, not size.
Size, yes, absolutely. So,
That's
they did look
interesting.
at the size, but that wasn't statistically significant. Okay, so I'm back at Karina. So we looked at station 4L.
And can you just highlight visually on the endoscopy view,
Yeah.
the endoscopic view, you're just above the carina,
We're
about
just
1
gonna-
or 2 cartilage rings, is that right?
Right.
Yes, 1 cartilage interspace above, and then turn anti-clockwise, 9 o'clock
90
position,
degrees.
and touch to left lateral
Okay.
wall of the trachea, and then
And
it's 4L.
when you do that maneuver, when you go anti-clockwise for the beginner, do you tip up? Do you angle up? You don't.
No,
You just
move the
about.
hand.
Just rotate.
Just
Yes.
rotate the hands, and
Absolutely.
I mean,
And then,
beautiful image.
and then you do the tip up in order to sort of thumb down,
Yeah.
so there is a good contact.
So that you get apposition of the
Right.
processor onto the mucosa.
So whenever we say rotate anti-clockwise or clockwise, what we're talking about is subtle movement to the wrist.
Yep.
That's all.
Yep.
Okay.
Yeah. Okay.
So the next landmark is subcarinal node from the left. So that's probably one of the most easiest to identify. So you just go close to carina and slide 1 or 2 cartilage interspace below, and that is subcarinal node there. Again, you can see.
Okay. Can we just have about a 5-6 centimeter depth
Yeah,
of field?
I
That's
brought
great.
that up. About there?
Yeah.
6 is fine.
6, okay.
Yeah, that's perfect.
Yeah.
Perfect. Brilliant.
So this is so you went down the left main bronchus there, or just on the tip of the left main bronchus?
Yes, so just sitting below carina, literally just sitting below carina.
Okay.
If I come up, that's it. You can see I'm now in the trachea.
Yep.
So
you're almost going
so
clockwise
that is carina, and touch it and 1 cartilage interspace below, and that's it.
inserting the bronchoscope through.
Indeed.
So
Okay.
you're just in the proximal left main bronchus
Yeah.
and rotate about 90 degrees clockwise this time.
Okay, perfect.
Oppose the probe on the mucosa wall,
Yeah.
and you'll
So that's
You
3
should
o'clock
pick up.
position.
And the name of this node,
station 7. It's subcarinal node.
this is the station 7.
Yep.
Okay,
Yeah.
perfect.
Okay. And then again, we come back in the left main bronchus. I'm just trying to clear up the view. Okay, this is a better view. So this is carina, going to the left main bronchus. Now landmark 3, 1 to 2 cartilage interspace below, and at 12 o'clock, this is where normally you would see 10L, which sits below left main pulmonary artery. So the one that you're seeing is left main pulmonary artery.
Here?
And it's
Here?
yes. And just below that there should be 10L. But I can't see
Node,
it.
no.
Nodes there. Yeah,
So
it's
that
all clear.
station is clear.
Yes. So
No,
And
10L
that
is
is
clear.
10L.
That's
Okay.
fine. On the CT, we definitely saw a small 11L lymph node,
Okay.
Okay.
but we're not going to go there yet.
No. So we've done 3 landmarks so far. Again, 4L, station
4L.
7 from left, and 10L, which is left hilar. Now come back to Carina.
Carina.
Then you go down on the right hand side, so right main bronchus for station 7 from the right hand side. So just below Carina, turn your hand 90-degree anti-clockwise at 9 o'clock position, and that's station 7 from the right.
Perfect. And this is the same node
That's the same node.
that we were looking at on the other side.
Indeed. So landmark number 5, as per the combined statement that I talked about, is 10R, which is, sorry, I'm just trying to clear up the view. Lots of bubbles.
A little bit of mucus, perhaps.
That's better.
Okay, that's better. So for 10R, then you just go proximal to the origin of right upper lobe bronchus that you
Yep.
can see at 12 o'clock position. So you come up and just proximal to the origin of it should be 10R. So that's
And
10R.
And here it does look as if we're picking up something.
Yes. And I will gently come up because I think that's an azygous vein coming into SVC.
So, Ray,
Okay.
can you just turn the gain up a little bit?
Yeah.
Yes, yeah.
Yeah, perfect.
So that's, I think, azygous vein there. And if I... Do you agree, Andy? It's obviously squashed between 2
Yeah.
huge nodes, but as I move my hand, if you can just follow with arrow, Ray.
So is
that's
this
at-
the...
Yeah, no, go up. Yeah, that's the one. That's the one.
Uh-huh.
And then,
It
track it
follows.
down.
Track it down. It's squashed in
there we are.
between 2
Very,
nodes.
very nicely shown there.
Wow.
Yeah.
So we're actually looking at the SPC being compressed
Yes.
Well,
That's-
here
certainly a little bit, but you could really...
with this bulging.
That is 10R.
Yep.
And just on this side, on the right hand side, is 4R. And there is a
Yep.
small azygous vein which is compressed by the size of 2 enlarged nodes.
And it's coming out through here.
Yeah, yeah.
That's
Can you
extraordinary.
appreciate it?
That's
Yes.
extraordinary.
Yeah.
Can we? Can you indulge me if we put a Doppler
Yeah.
onto here? Would that be okay?
Yeah.
So I do. So I take this off, I think. No,
So
I
you've
don't
got,
take
you've
that.
got pulse wave Doppler there,
So Doppler,
colour flow Doppler.
color flow.
Yeah, you can see there.
So we have SVC below, and we've got
Azygous vein.
the Doppler
Yeah.
demonstrates it beautifully here, doesn't it?
Indeed.
So SVC here, and then can you see it? Can you trace it so it's actually coming off? It's really quite tight.
Yeah. So that's up at 12 o'clock. And then
Okay.
as I trace it down, it then opens into the SVC. So
Okay.
it's got a bit of cuff. So that's landmark number 5, and we'll
Okay.
quickly do the landmark number 6, which is 4R. Again, you sit up Carina, 1 to 2 cartilage interspace above, and around 1 to 2 o'clock position. So you turn your hand clockwise about 70 to 80 degree, and there is 4R.
Wow.
Again, can we just have the gain up a little
Stunning.
bit? It's
Yeah.
yeah, okay. And the SVC is a little bit compressed.
Yes, it is.
Yeah. So the compression point is just here, so it's why
Yeah.
it's widening, and then it's
Yeah. And again, if you
flow
look,
limiting there. Well, maybe not flow limiting, but
yeah.
it's certainly compressed.
Again, if you look at the node, you know all those features. So
Very
round
big.
shape,
Round.
distinct margins,
Yep.
no central hilum,
No.
and heterogeneous echogenicity.
Yep.
So it is very likely to be malignant.
Yep. Okay. If I just again, just indulge me for a second, so we can just hone in on that.
Yeah. So very clear distinct margins
Really.
and round shape. Sorry, yeah, that's so 4 features: round shape, distinct margins, heterogeneous echogenicity, and central necrosis or loss of central hilum, either or.
Now, do we have any clear areas of central necrosis here? Maybe.
Well,
No.
I think you have got some darker
Yeah, I
islands
think
in
I
there.
think
Those
I
are-
would agree. Yeah,
So that's sort of areas
and
of
maybe up
yeah.
here
Yeah.
as well. It's area of central necrosis there, I think.
Yeah.
Okay.
So
Perfect.
we just
okay.
need to make a decision about where to
Okay.
biopsy.
Yep. Should we go for 4R then?
Yeah.
Because it's more of a diagnostic than staging.
Yep.
Okay. Can I have some lignocaine, please?
22 gauge standard, please.
So I've got some noise.
Thank you.
So you're putting lignocaine
Just a-
down the linear echobronchoscope.
Yep.
Yeah.
Thank you.
And if you don't mind, sort of, because last time I couldn't give the full detailed commentary of needling.
Yeah. So
Dave.
we're just going to insert the needle into the scope now, down the operating channel of the scope. At the moment, the needle is retracted, so it's safe and it's hidden within the sheath. And the key and most important part here is to not damage the equipment. And for that reason, you have to see the sheath visible endobronchially. And
So we can just see it
Just
1
emerging at
Yeah.
1 o'clock on the endoscopic image.
so we know that now when we deploy the needle, it is
It's
not
protected.
inside the operating channel of the telescope.
I understand. So that's a very, very important step.
Secondly, I've already visualized the node target, and it's at least 3 centimeters. So I'm setting the needle length to no more than 3 centimeters in the first instance.
Okay.
This is a standard rather than a Procore needle, so we usually have about 1 centimeter of the stylet withdrawn,
Okay.
which exposes the sharp needle tip.
Okay.
Okay,
And this is a 22
gauge.
22 gauge FNA
Yeah.
Cook needle.
Yeah.
Okay.
Okay. Sorry, I think this is slightly loose. Yeah, that's okay. Right. And that's 4R in action again. Sorry, Andy, it's slightly.
And that's perfect. So, needle.
Yeah, go for it. Brilliant.
So, again, a few movements in and out with stylet ensures that you displace any mucosal plugs which may be sitting in the tip of the needle. This syringe is preset with suction or vacuum. Now we're just going to biopsy the node.
So these are very nice, slow, as you say, agitations.
Agitations, indeed.
Okay, so going back and forth.
So we like to go from edge to edge.
So all the way back and all the way forward.
Indeed.
And I guess just like in EUS, it's important to visualize the needle
Absolutely.
tip.
Tip of the needle,
It's the most
absolutely.
important area to visualize, I guess.
And sometimes what happens is the needle becomes bent,
Yes.
and so not all of the needle
No.
shaft remains within the
Yeah.
linear probe picture.
But of the whole needle length, the only area that we definitely need to see is the needle tip,
Which is there,
which is here.
which is
think.
well short of the capsule.
Capsule.
Yeah.
And again, we're getting some nice air artifact within
Yeah,
the
yeah.
node itself, which tells us we've been in the right place. So we draw the needle.
So again, this node is in. This is
4R.
4R.
Right
And
lower
you're,
paratracheal.
and you're sitting in the right main bronchus.
No,
No,
I'm
you're
sitting in trachea.
the trachea. Fine.
Yeah. All right, so you're doing very well. I'm afraid every time the needle
Did you
comes
get the
out, it does make you
characteristics,
cough a little bit,
yeah.
but you're doing really well.
You tell me.
Just a couple of things about the.
So I might just annotate. Well, sorry, no, you
Yeah,
go
no,
first.
see, the agitations, as I said, the guidance recommends between 5 to 15. However, at least I'm not aware of any studies, unless you're aware of any studies where the exact number's been mentioned. But
You mean 5 to 15 agitations?
agitations,
Yep.
yeah. So,
Yeah.
or jabs, as we sort
Yeah.
of put it in simple terms, while we're on the nodes. On an average, we do it at least 20 plus
Yeah.
in our practice.
Yeah.
And the recommendation is where the road service is not available, at least 3 needle passes to be performed.
Yes. And
But actually, what we've noticed when reviewing our data is that certainly 3 years ago, we were on average passing the needle in 3-4 times, but it's now gone up significantly, and that's because of the need to get material
Yield.
for next generation sequencing.
So immunocytochemistry or molecular staining. Yeah. Okay.
Okay.
Yeah.
So you can see the needle going in on the endoscopic view. But this is quite a good demonstration that when you see a very good endoscopic image, you don't always get a good ultrasound image, because on the endoscopic image you have air in the lumen. But as soon as you lose your endoscopic image, then you start to get a very good ultrasound image.
Now I'm actually in the periphery of the node here.
Yes.
And actually I don't mind that. Our pathologist has taught us very well, and malignant material moves from the periphery towards the centre. So
what we're talking about here, rather than being in the centre of the node,
correct,
you're actually targeting. This is the periphery here. This is it. So you're actually traversing on the very edge of the node.
Yep.
Yep.
And we found in our experience that you're much more likely to have viable tissue here.
Yep.
Indeed.
As this node is growing, whereas in the centre, you may have some necrotic material.
Intuitively, you avoid the central necrosis.
Yeah.
Feels firmer here, actually, funnily enough.
Do you notice that every node is different? That some can be soft, some can be quite hard.
The hardest one are the fibrosed sarcoid.
Right. Okay. Yeah. And probably the tissue yield as well could be.
Does get affected.
Be
indeed.
tricky. Yeah.
All right. Sorry, we've taken the needle out. I'm afraid every time we take the needle out, it makes you cough. You're doing really well, sir. You're doing really well. Your oxygen level, your pulse, everything absolutely fine. You've been an absolute star.
Yeah.
So one of the benefits of transcricoidal infiltration, at least we found in our practice, is despite low level of sedation, patient is quite comfortable.
Yes.
Now he does cough every time the needle is taken out, and again, I'm sure Andy will agree with me. We have seen in our practice, whenever the needle comes out, patient do tend to cough a little bit.
Now, is this because it's irritating the cartilage ring as
or
it
whether
comes
it's
out,
mucosa,
or whether it's mucosa
when you're
mediated?
still, just for the benefit of the observing audience, pass 1 into that node was diagnostic.
Diagnostic. Okay, fine.
So we don't need to make any more slides now.
No.
And so we're harvesting for cell block.
For cell block.
And additional
For
works.
for molecular markers.
Yeah.
Okay.
Yeah.
So the stylet is coming out. The needle is about here. The tip, I think, is here.
That's correct. And then you can
and
see.
And as the vacuum goes on, you can actually see the bubbles tracking up, which I think is a good sign that the vacuum is working. I think one benefit of being in the central part is that you get a longer throw from all the way in the proximal end to the other side, the margin of the lymph node.
But what we do know from the slide we've made is it's quite a necrotic.
Necrotic node.
In terms of volume that we're getting and worms,
I think not very much. The second pass was pretty scanty. Yeah.
If we're getting scanty, should we switch to
that's why I was-
Procore?
I don't think it's. I think it's because of the
I think you've got a little bit of
heterogeneity.
secretions at the back of your throat. We're just doing a little bit of suctioning. Bear with us, you're doing really well. Sorry, what did you say, Tony? Do we need to switch to Procore, or you're happy?
I don't think the Procore will help. I think it's the heterogeneity of it and the focal necrosis is the issue. So I don't think you need a cutting needle. It's just it's a question of the variability of the material itself.
Okay.
So would it be best to think about more material from the periphery,
Well,
but
what we could-
maybe more agitations?
What we
perhaps?
could do is try a different node target.
Yeah,
Yeah.
yeah,
Um,
yeah.
See if we can get more viable.
Oh, it's
Material.
purulent, isn't it?
Should we go
Actually.
7, because it'll be convenient. I will
Yeah.
look at this.
Yeah.
Yeah, it's very it's kind of purulent looking.
Okay. We'll go
Okay.
for station 7 then.
Okay.
I think this is the beauty of ROSE,
Absolutely.
is that
Yeah, they're gonna move
you
to 7.
have this instant feedback. ROSE, by the way, for the beginner stands for,
Rapid on-site evaluation.
so rapid on-site evaluation is giving us an immediate feedback in terms of how much material we're getting.
Sorry, 1 second. I lost the...
So is this still 4R?
Yeah.
Have you gone to 7?
Yes,
We go to
station 7
7.
now.
This is 7.
Yeah.
Okay. Sorry.
And how did you get to this node? You went down which side?
So I went down in the right main bronchus.
The right main bronchus,
And then,
and then faced the scope medially,
medially.
turning into the station
Indeed.
7
Yeah.
node. Whilst you're doing that, I wonder if I can annotate. So we have station 7. And we have this area here. Lymph node. Do we have lymph node? I'm not sure if we do. Oops.
Yeah, so we will need to slide from the first one, obviously.
And then
No,
we'll take this off.
Alright, so sorry. We've taken the needle off, and that's making you cough.
Okay. And then we'll
Gonna do a
record
little
this.
bit of
Do we-
suctioning.
Or we just
Back
freeze
of
it like
the
that
drawer.
for a
Bear with
second.
us.
This one?
Better volume now.
Yeah,
Okay.
looks a bit.
And then, okay. And then we can carry on.
Should we put a
It's
little
a
bit
bit
of
of
down
nice
already?
volume.
Oh, I'll leave them. Perhaps.
Ladies, where have we kept local? Thank you. Yeah, go for it.
Getting a little bit.
Alright, so we're just putting a
here.
little bit more local anesthetic. Give it about half a minute or so, and it will help to settle your coughing. Sorry, Andy, 1 second. Let me get.
Okay, I'm ready.
So this is this carina. You're going down the right main.
Might just.
I think I'm in left main now,
Yeah, I think
Okay.
you are.
and that's
Left
where
main.
it is. That's
Lovely.
the area of interest.
Okay, these are nice images.
Indeed.
And as you've said before, it's really important to visualise the needle for its entire length so that you're conducting a safe test. Now I'm actually,
You can see the telltale sign of the needle there.
so
Tip
I've,
is actually
I've
there.
stopped the needle there. I'm going to set the needle length so that it cannot go beyond that
Yeah,
point.
got you.
So we can now conduct a safe process of agitation or passing the needle in and out of the lymph node. without transgressing the capsule, without going into adjacent vascular structures.
There's a great deal of research from the EUS side in terms of how many passes or agitations, but it's very difficult to really do this, I think,
Indeed.
under strict scientific conditions, because every tumour is different, every lymph node is different.
Yeah.
Indeed.
Stick it in there. Tricky. Is it that side? I think it's that side, doesn't it? It must be, because that's the side you've labelled. Yeah, okay.
Got it?
Yeah.
So while we're waiting for the needle, I'll just quickly recap those 6 stations.
So that would be
or
great.
6 landmarks.
Yeah, that would be fantastic.
Station 4L to start with.
Okay.
To look at endobronchially, you sit just above carina. You come up by one interspace cartilage above,
Yeah, so
and then
again,
rotate
it's pretty
anti-clockwise to
Anti-clockwise,
9
90
o'clock
degrees.
position.
Just
about.
Yeah,
Okay.
90 degrees to 9 o'clock position. Then landmark number 2 is station 7 or subcarinal node, which is basically just sitting below carina. So you go in the left main bronchus, just below carina, turn clockwise 90 degree again at 3 o'clock position.
Really?
Okay.
That's station 7 subcarinal. Then you come back again in the left main bronchus, and you go 1 to 2 interspace cartilage below from carina at 12 o'clock position. That will be station 10L. So we've done the 3 landmarks on the left hand side. After this pass, we'll do the remaining 3 landmarks.
Okay. So a nice, very, very nice view there.
All yours, Sandy.
Thank you.
So there's telltale signs of air, I guess.
Yeah.
Okay.
These are very, very nice images here.
So yeah, that's air artifact from the previous pass, isn't it?
Yeah, yeah.
Yeah.
And we're going into different parts of the lymph node now.
Yeah.
Just
So there
Doing
wasn't
very well.
anything
So
from
we're
that
just getting
second
more
pass.
samples. You're doing really well.
No.
so once again, I'm going to set the needle length, so we cannot go beyond that point.
In the EUS world, there's a technique where you can change different trajectories through. I think we call it fanning.
Yep.
Fanning, but it would be very hard to do that.
We can do it with a manipulation of the scope
the
lever.
up
Yes,
down.
we can.
Okay. Looks like there's a little bit of secretion, sir, at the back of your throat. Just clearing that up.
Yeah.
Okay. So coming back to our landmarks again on the right hand side. So you start with.
That was better material from that
Sorry,
pass.
1 second.
Okay.
All right, sir. You start with station 7 from right hand side. So you go down in the right main bronchus.
Yep.
Just below carina, you turn anti-clockwise 90 degree at 9 o'clock, and that's station 7 from right. Then you come back in right main bronchus, and just before the origin of right upper lobe bronchus, you turn 90 degree clockwise at 3 o'clock position. That's for station 10R.
Okay.
These are the endobronchial landmarks and the sort of endobronchial sites where to go for these landmarks. And the last one is station 4R. You come back in trachea. Yeah. Go for it. Okay, so sorry, I'll quickly finish with sixth
Yep.
landmark now. So you
Yep.
come back in trachea, 1 to 2 cartilage interspace above carina at 1 o'clock position, which sort of you rotate 70 degree or so clockwise, and then that is where the 4R is.
So that second pass into 7, that's very good material.
Excellent.
So not necrotic.
Okay, that's good.
Okay, so that's
Yeah.
where we've gone back.
That's where
Yeah.
you are now.
And that's the
Yeah.
benefit of rapid on-site evaluation.
Yeah, that's the beauty
especially
of
where
rules.
you have
Yeah.
the node quality which borders on necrotic in
Yeah.
places that
Yeah.
you can go back and harvest from the site where you know you've got viable
fine.
material.
Yeah.
Yeah, no, that's fine. That's okay. So so that is that one, isn't it?
And if you don't have rapid on-site
So we just
evaluation,
need to
you
block
just have to
everything
guess.
You're
and hope
working
for the
blind.
best.
Yeah, I totally agree. I think there are so many benefits to ROSE. The first is having immediate feedback,
Okay.
which for me, like a photographer, as a photographer, I look at the LCD screen on the back and on back of the camera, and I know immediately if I have the shot or not, and then I keep going until I get that shot. But I think if we're doing it blind, then it means that we're going to have to do more agitations, but also more passes
Yeah.
per lymph node station, I think.
So it is ultimately better for the patient.
Yeah.
Okay.
And probably also there is some data to suggest safer, because fewer passes may, at least in the US world.
Tony, have we got enough or?
Cell block wise, I think that was good, and the previous one was good. But it'd be due to get another one if you can.
One
Okay,
more.
yeah,
Yeah.
we can do one more.
Yeah.
Okay.
One
Now,
more
which,
and then
which
finish.
station is this again? This is
All station 7.
subcarina.
Yeah.
So station 7.
Yeah.
How's that looking?
Okay.
Oh, not bad. Not bad, actually.
Tony, have we given you the node characteristics for 7?
No, nor did you for 4R.
Okay, well, we'll do 7 first of all. It's about 35
Yeah.
millimeters,
Yeah.
heterogeneous, lobulated central necrosis.
Okay.
And 4R was exactly the same, but was
Round and distinct margins
With,
for 4R.
4R was the same, but size-wise was smaller, about 25.
Okay.
We're on the last sample, sir, so hopefully another 30 seconds or so.
So this is a very, very nice, very clear FNA pass.
Again, for the benefit of audience, it's very common to see patient tends to cough when the needle is
Is
removed
pulled
or
out,
withdrawn.
removed,
Yes, yeah. As long as that coughing settles within few seconds, it's fine.
Okay.
If it doesn't, you can always put some extra lignocaine.
So again, we can see a few flecks of gas here.
Indeed.
One or two flecks of gas here.
Okay.
Okay, we're finishing, I think.
Yeah,
This
I'll
one's
just wait
coming, it's gonna be
for
separate.
confirmation that we got decent sample, and then we will come out. Nearly done, sir. Just give me 20 seconds to confirm we got good sample, and then I will come out. Try not to talk, otherwise your
Okay.
back of your
So
throat
this
will
is
go
much
sore.
more quite cellular.
Nearly
All
done.
viable, no necrosis here, and actually has a kind of
Decent material, team.
papilliform
Okay, all right.
look to
That's
it.
it. I'm coming out. Very well done.
Okay.
Yep.
Very, very nice demonstration.
Hello, my name's Andy Barlow. I'm one of the respiratory consultants here at West Hertfordshire Hospital's NHS Trust. The point of making this short video here is to demonstrate that this is absolutely a team effort. A complex endoscopy requires everybody to play their part. So I'd like to first of all thank the endoscopy nurse team who are scattered around here in the audience. I'd like to introduce the pathology team.
Hello, I'm Winnie Tang. I'm one of the senior biomedical scientists. I make the slides for the pathologists to look at.
And I'm Dr. Tony Maddox, and I'm the pathologist that she makes the slides for.
I'd like to thank my endoscopy colleagues.
Ray McCrudden, gastroenterologist from the Royal Bournemouth Hospital. I do endoscopic ultrasounds, not EBUS, but I'm very flattered and grateful to be asked to be part of the teaching and training today.
And
Thank you. I'm Rahul Mughal, one of the chest physicians, works at Watford General Hospital, West Hertfordshire Hospitals NHS Trust, and as my colleague Dr. Barlow mentioned, this wouldn't have been possible without the teamwork, and that involves endoscopy staff as well as pathology and Dr. McCrudden coming all the way from Southampton. Thank you. Bournemouth, sorry.
so once again, a final thank you to everybody for a fantastic day, and let's look forward to the next training video.